Hi folks, in today's lecture I shall be talking about the angina or angina pectoris and its pharmacotherapy. Now this plaque or the atherosclerotic plaque is basically composed of fat, cholesterol and different salts such as calcium and some clotting factors such as fibrin. Patients sometimes describe this pain as if someone is sitting on their chest. This is the same situation when you play cricket or football and your muscle in leg or arm starts to fatigue. Because overuse of your leg or arm muscle will cause pain, the difference is that one can stop running or bowling, but the heart cannot stop. It cannot stop beating, or this specialized muscle is not designed to rest or take pauses. Hi folks, in today's lecture I shall be talking about the angina or angina pectoris and its pharmacotherapy. So let's have a quick look at the topics. We'll discuss what is angina, the pathophysiology and different types of angina, the symptoms of angina and the pharmacotherapy. And the pharmacotherapy includes the anti-anginal drugs and their classifications. So let's see what is angina. Angina is a chest pain or discomfort. We often say it's discomfort rather than pain, which results from a disturbance in the oxygen supply or demand ratio. But we shall have a closer look at this ratio disturbance in coming slides. The pain may radiate to your shoulders, arms, neck, jaw or back and is termed as referred pain. Now, referred pain is a pain which is felt in the regions around the chest. Now, the regions around the site of its actual origin, which is the chest. So it could be anywhere in the shoulder, jaw or the lower jaw, neck, chest, arms and upper abdomen. And this upper abdomen pains feel like indigestion. So the pain may also be felt in the upper abdomen, as I said, as if someone is having an indigestion. Now, angina may be a warning sign for the myocardial infarction or MI. And this usually happens when one or more of the coronary arteries or its branches are narrowed or blocked, and the supply of oxygen to the heart muscle is reduced, and we call this condition ischemia. Now, like any muscle of the body, the heart muscle requires its own constant supply of oxygen and nutrients. The two large coronary arteries, the right and the left, branch out into a number of small arteries that deliver oxygenated blood to the heart muscle. Now, if one of these arteries or its branches become blocked, a portion of heart will be starved or deprived of oxygen, a condition called ischemia. And that is why all these related cardiac diseases are known as ischemic heart diseases or coronary artery diseases or CADs. Now, if cardiac ischemia lasts too long, the starved heart muscle or the heart tissue will die, and we call it heart attack or myocardial infarction or MI. Now, infarction means death, so this is the death of the heart muscle. Now, how this ischemia or restriction in blood supply will occur? The ischemia basically develops if there is a plaque formation in the coronary arteries or its branches, restricting the blood supply to the myocardium or the heart muscle, leading to atherosclerosis. So this condition is known as atherosclerosis, which may lead to death if left untreated. So this is the same coronary artery and its branch, and there is a plaque formation here. Like you see here, there is some blockade, and which is offering resistance or hindrance to the flowing blood. So the heart muscle, which will eventually receive the blood, is now deprived of oxygen and the nutrients, and this will then lead to the death of this part of the myocardium. Now this plaque could be some deposits of fats and some minerals which will deposit over it and cause this blockade. Now the research tells us that if this blockade in the coronary arteries is almost 70%, or it reaches up to 70%, there is a chance that the patient may have an angina attack. Now if this blockade tends to 100%, the patient may have a heart attack or myocardial infarction. Now the main difference in anginal pain and the MI pain is that with angina, the blood flow is restored, the pain is relieved within minutes, and the heart is not permanently damaged. Whereas with a heart attack or MI, the blood flow is critically reduced or fully blocked. As I said, it's almost 100% blockade in case of MI, and the pain lasts longer and the heart muscle dies if emergency medical help is not provided. However, there is one interesting point, that about 25% of all MI or heart attack cases occur without any previous warning signs or angina, because angina is a warning sign for MI, and we call this phenomena as silent ischemia. So the condition may be detected, however, by electrocardiogram or ECG testing. People with diabetes often have silent ischemia, so beware about that. Now what about the recovery after an MI attack? Now recovery from an MI or heart attack is always a tricky and a delicate process, because any heart attack will weaken the heart muscle to some degree, but generally a normal life can be resumed after survival, depending upon the severity of heart attack a person may experience. Now let's see what are some post-MI complications which occur after an MI attack. So they include heart failure, where the heart does not pump enough blood to meet the body's demand. So this heart muscle will not sufficiently pump the blood into the rest of the body. Arrhythmias or abnormal heart rhythms may occur after an MI attack. Cardiac arrest or sudden cardiac death, where the heart stops beating. Cardiogenic shock, where the heart is so damaged from the heart attack that a person goes into shock, which may result in damage of the vital organs like kidney or liver, and this may eventually lead to death. Now, as you know that I already mentioned that we shall have a detailed look at the oxygen demand versus oxygen supply ratio, so let's see what actually happens. Now in this scenario, we are basically comparing the efficiency of a healthy heart versus a heart with a CAD or coronary artery disease. So we are basically comparing these two hearts, a normal heart as compared with a heart with a CAD or coronary artery disease during rest, when there is an equilibrium between oxygen supply and oxygen demand. Now upon exertion or during exercise, the normal heart is capable of maintaining an equilibrium between oxygen supply and oxygen demand, whereas the heart with a CAD or coronary artery disease will be in serious trouble, because now, as you can see, the system is off balance. The oxygen demand is higher, whereas the oxygen supply is restricted due to the blockade in the coronary artery or the clot formation in the coronary artery, and this could eventually lead to angina or MI. Now, before proceeding further, let's have a quick look at the following terms: atherosclerotic plaque and infarct and infarction. So here we have a left coronary artery and its branches, and the right coronary artery and its branches. Now, the clot formation anywhere in the coronary artery or its branch may lead to an infarct. Now, infarct is that dead area of the heart muscle which has occurred due to the cessation of blood, or in other words, cessation of oxygen and nutrient supply to this area of the heart. And this could lead to the death of this part of the myocardium, and we call it myocardial infarction. Now, this is the zoom in of this blocked branch of the left coronary artery. Now, this plaque, or the atherosclerotic plaque, is basically composed of fat, cholesterol, and different salts such as calcium, and some clotting factors such as fibrin. This is a deadly association of all these agents, which will eventually lead to the cessation of blood supply to a specific part of the heart muscle and lead to the myocardial infarction or death of the myocardium, and thus causing serious cardiovascular accidents. Now, let's see what are the different types of angina. So the first one is stable angina. We also call it exertional angina or classic angina. The stable angina is the most common type, and it follows a pattern and is precipitated by activity, or aggravated by activity, or worsened by activity or exercise or stress, and is often relieved with rest and nitroglycerin. So if the person has some rest or takes nitroglycerin or puts this nitroglycerin or NTG tablet underneath the tongue, the condition can be relieved. So as you can see here, this is a coronary artery. The blood supply to this part of the myocardium is restricted due to this plaque formation, and this is a classic example of stable angina or exertional angina or classic angina. The next type is unstable angina, and of course this is the dangerous type. It does not follow a pattern. That's why it's dangerous, and can happen at rest. This can happen when the person indulges in an activity or exercise, while this one happens even at rest. It does not go away with rest or nitroglycerin. So a total contrast. This goes away with rest by taking nitroglycerin, while this does not. It is a sign that you could have a heart attack soon. That is very dangerous. It is also called acute coronary syndrome. So, acute coronary syndrome. Now, the most common cause of unstable angina is the coronary artery narrowing due to a thrombus or a blood clot that develops on a disrupted atherosclerotic plaque. Now, this is a coronary artery, and this is the plaque that I have been discussing so far. Now, there is a clot formation somewhere around here which will increase the blockade. So this is a thrombus formation basically, and on top of that plaque, now here as you can see, there is a clot formation which will cause severe blockade of the coronary artery and can lead to unstable angina. So there is acute coronary syndrome condition here, or a buildup of clot or coronary thrombosis on top of the plaque. So of course this is much serious condition which could lead to serious cardiovascular events. And the third type is Prinzmetal's angina or variant angina. Now, unlike typical angina or stable angina, which is often triggered by exertion or emotional stress, the Prinzmetal angina almost always occurs when a person is at rest. So that's dangerous, and that usually happens between midnight and early morning, and these attacks can be very painful. The pain from variant angina is caused by spasm in the coronary arteries. Always remember this term. Prinzmetal angina or variant angina is caused by spasm or constriction in the coronary arteries. The coronary arteries can spasm as a result of exposure to cold weather. Some medications such as vasoconstrictor agents, for example ephedrine, smoking and cocaine use. So always remember one thing, that Prinzmetal angina or variant angina is caused by a spasm or constriction in the coronary arteries. That is very important to bear in mind. So spasm in the coronary arteries could be triggered by any of these factors, such as exposure to cold weather, certain medications like ephedrine, smoking, cocaine use. All these can lead to constriction of the coronary arteries, and you know, when there is constriction or spasm of the coronary arteries, there is a restriction in the blood supply to the myocardium, which is called the angina. So in short, the Prinzmetal angina is not due to a coronary blockade, but due to the constriction of coronary arteries, and this can even happen at rest. Signs and symptoms of angina. So the classic description of angina include crushing pain, heaviness or pressure, which is often described as discomfort, that radiates across the chest, sometimes down the arm, into the neck, jaw or teeth, or into the back. It may be associated with shortness of breath, nausea, vomiting, sweating and weakness. Some people instead describe it as a sensation of indigestion when walking, and also a feeling of fullness, tightness, burning, squeezing or ache. Usually people do not recognize that their symptoms are due to a heart disease. They usually experience inability to perform work or other activities that had once been easier to do. They may feel increased shortness of breath with the activity, like walking up steps or uphill. The pain can even stop you in your tracks. However, it is more worrisome when the pain comes at night or during sleep or during resting hours. This is the same situation when you play cricket or football and your muscle in leg or arm starts to fatigue. Because overuse of your leg or arm muscle will cause pain. The difference is that one can stop running or bowling, but the heart cannot stop. It cannot stop beating. Or this specialized muscle is not designed to rest or take pauses. Miguel Garcia suffered heart attack during a Spanish division match. The 31-year-old collapsed on the pitch after 61 minutes of play. The emergency services arrived onto the scene, and fortunately he was brought back to consciousness. He survived and a tragedy was averted. Now let's come to the point. What are the different therapeutic strategies of angina, or the classification of different anti-anginal drugs? Now we have three categories: the drugs which decrease oxygen demand, which include vasodilators, and cardio-inhibitory drugs. 2. The drugs which increase oxygen delivery, and they include 2. The coronary vasodilators and antithrombotic drugs, and others which include late sodium current blockers. Now, what are the different therapeutic strategies for treating chronic stable angina? So we have drugs which decrease oxygen demand, and they can be very helpful in treating chronic stable angina. These include vasodilators and cardiac depressants or cardio-inhibitory drugs. So initially the situation is like this: the oxygen supply to the myocardium is insufficient to meet oxygen demand. So more oxygen demand, less oxygen supply, and when we take these medications, there is an equilibrium. So the oxygen demand is reduced. Oxygen demand is reduced to balance out the supply-demand ratio. Let's have a look at the drugs which decrease oxygen demand. These include vasodilators or cardiodepressant drugs or cardio-inhibitory drugs. So the vasodilators include nitrodilators and calcium channel blockers. The well-known nitrodilators used are nitroglycerin or NTG. We also call it glyceryl trinitrate or GTN. Another one is isosorbide dinitrate, isosorbide mononitrate, and sodium nitroprusside. The calcium channel blockers include diltiazem, verapamil, amlodipine, felodipine, and nifedipine. Now, the classical drugs used for the management of angina include nitrodilator drugs. On the other hand, calcium channel blockers are often used as antihypertensive. However, they are additionally used in the management of angina also. Now, nearly all of the drugs are used in the management of angina, including diltiazem, verapamil, amlodipine, and felodipine. Most importantly, the longer-acting versions of calcium channel blockers, including diltiazem, verapamil, amlodipine, and felodipine, are basically the drugs which are used in the management of angina. Nifedipine, especially its short-acting forms, should generally be avoided in people with angina, since the pronounced blood vessel dilation produced by this drug can lead to reflex sympathetic activation or the release of adrenaline, which will eventually cause cardiac stimulation and thus producing tachycardia or the rapid heart rate, and consequently an increase in cardiac oxygen requirements. So short-acting nifedipine can usually worsen the cardiac ischemia. Now let's see what are the different cardio-inhibitory drugs used to reduce the oxygen demand of the myocardium. Now these cardio-inhibitory or the cardiodepressant drugs include calcium channel blockers. Yes, they are also present here. They have an additional effect. And the non-selective beta-1, beta-2 blockers, the selective beta-1 blockers. Now, non-selective beta-1, beta-2 blockers include labetalol, nadolol, penbutalol, pindolol, propranolol, and timolol. So that lovely olol or lol group. And selective beta-1 blockers include acebutolol, atenolol, betaxolol, bisoprolol, and metoprolol. Whereas calcium channel blockers include diltiazem, verapamil, amlodipine, and felodipine. Now, in general, while calcium channel blockers are useful for relieving angina, they may be considered inferior to beta blockers. Now, the calcium channel blockers should be tried in patients who cannot tolerate the beta blockers. And the calcium channel blockers should be added to the beta blockers in patients who have insufficient relief of symptoms with the beta blocker drugs. Now here let me tell you about one controversy, and that is a medical literature controversy that says that black people and older people respond better to calcium channel blockers than the other drugs. So there are so many speculations about that, but there is no known reason for that available so far. Now we shall have a look at the therapeutic strategies for the unstable and variant angina. So here, as you can see, that there is a very little oxygen supply. There is more and more oxygen demand, and here, as you see, there is oxygen supply to the myocardium which is insufficient to meet oxygen demand. So here, as you see, the oxygen supply is improved to balance out the supply-demand ratio. Now the drugs included in this category include coronary vasodilators and antithrombotic drugs. Now let's see them one by one. The drugs which increase oxygen delivery include vasodilators, the same nitrodilators and calcium channel blockers that you have seen a few slides ago. So nitrodilators include the same drugs: isosorbide dinitrate or isosorbide mononitrate, nitroglycerin or glyceryl trinitrate, sodium nitroprusside, and the calcium channel blockers which include diltiazem, amlodipine, felodipine, and verapamil. Now the antithrombotic drugs include anticoagulants and antiplatelet drugs, because as you know, in unstable angina there could be a clot formation, a thrombus formation. Now in dealing the clots or thrombi, we use anticoagulants and antiplatelet drugs. Now the anticoagulants include heparin and warfarin. Yes, the well-known drugs, the classical agents. And the antiplatelet drugs include the well-known aspirin, clopidogrel, so very commonly used drug, and ticlopidine. Now all these agents prevent the platelet aggregation and thus help in preventing the blood clot formation in the coronary arteries. And then we have a group which we can call other, and that includes late sodium current blockers. Now that is a comparatively new drug, and the drug is Ranolazine, and mind you, the Ranolazine is used to treat chronic forms of angina and is not suitable for emergencies or acute attacks of angina. Now Ranolazine could be used either alone or with other anti-anginal drugs to treat chronic angina. Ranolazine may be combined with a beta blocker or nitrates or calcium channel blockers. And this drug was first approved for medical use in the United States in 2006. Now Ranolazine inhibits the sodium current in the myocardium and eventually leads to the reduction in the intracellular calcium levels. This will then lead to reduced tension in the heart muscle and leading to the reduced oxygen requirements by the myocardium. So that's it for now. I'll see you again in another lecture. Till then, bye-bye.